It is my pleasure to introduce Paul Tang. Dr. Tang is a native Pittsburgher, yay. So a lot of great things come out of our city. His bio, I could talk for quite a while. It's quite a bio. He's now adjunct professor at the Clinical Excellence Research Center at Stanford. He's also a practicing internist. Recently, he was vice president, chief health transformation officer at IBM Watson Health, applying artificial intelligence technologies to improve the health and well-being of individuals and communities. Before that, he also directed the David Drucker Center for Health Systems Innovation, and he was one of the earliest people at the implementation of the electronic health record in this country. So blame Paul if you are frustrated with your EHR. He's been on a number, he's also a member of the National Academy of Medicine. He served on a number of study committees, and today he's going to be talking to us about one of his study committees. This is his second one on patient safety. He has also co-chaired the Federal Health Information Technology Committee from 2009 to 2017, and he's a member of the American Medical Informatics Association. He has a BS and MS in electrical engineering from Stanford and a medical degree from the University of California, UCSF. And one thing that intrigued me is he is so versatile that you might have seen his recent paper in the Journal of the American Medical Informatics Association on precision population analytics, population management at the point of care. He explores the potential of using index patients to match for precision medicine. So there's so many more things I could say, Paul. We really want to hear from you. Welcome.
Thanks so much, Karen. Are my slides up? All right. Wonderful. So thanks for this wonderful opportunity to speak to this group that is so energized and energetic about moving this agenda along. So I wanted to talk to you, as Karen mentioned, about a new NAM report. It's a peer review, and I'll explain that in a minute, of a draft AHRQ report on strategies to improve patient safety. So I'll give you a little, if I'll get these things to move, there. Give you a little history of what led up to this act of 2005, Patient Safety and Quality Improvement, give you some highlights from that, and then talk a bit about our peer review of this congressionally mandated AHRQ report, and some parting thoughts for your full court press. So we all know about this seminal report from the then Institute of Medicine from 1999 to Eris Human. So I'm going to give you a few of the highlights that are germane to this discussion. One of the recommendations said Congress should create a Center for Patient Safety in AHRQ. And why? To share and gather information and expertise so that we could understand what are the patterns and what could be done about it to make things better. Another recommendation was that, well, we've got to fill this repository, so we need to have mandatory reporting into it. And you can't have mandatory reporting if you don't protect the people who need to share very sensitive data. So a third recommendation is that Congress needs to authorize the ability to protect this information that goes into these repositories so that we could all learn from the aggregate data. This was really a very nice agenda for how we make patient safety better in the country. And as you know, this consumed many years of New York Times headlines in terms of let's bring to bear a national agenda to improve the situation. A few years later, IOM had a consensus study on patient safety data standards. And in it, we called upon national leadership to transform what we had, which is a system riddled with latent system failures, into one that we could be more proud of, where patient safety is not only state of the art, but a new standard for care. So that sort of sets up 2005 congressional action, the Patient Safety Quality Improvement Act, which, you think about, we used to in the old days have 5 and 10 years strategic plans. Well, in now's fast-moving world, you cannot, it's hard to produce 5-year, let alone 10-year. So if you say, well, what was the world like 15 years ago? That's also hard to remember and hard to think about. But I'll give you 2 reminders of what it was like in 2005. One, this was the smartphone. So the iPhone wasn't even invented until 2007. So it's hard to remember life without, and our kids have no idea what it's like without the internet. I showed my kids a picture of a slide rule, which is how I got my BS.
Yeah.
But at any rate, this is what smartphones were. The other part germane to this discussion is this is what a medical record was. So back then, 2005, fewer than 4% of us docs and hospitals had a comprehensive electronic health record system. That's just the way it was. You could not even detect patient safety events, let alone learn from them. So in that context, Congress put together this, sort of in response to the IOM report, the Patient Safety and Quality Improvement Act. Here are some of the high points. It's a very short provision. One is that there would be patient safety work products. These are the data that are gathered and analyzed for the purpose of improving patient care. That specific work product was not subject to subpoena, discovery, FOIA, or disciplinary proceedings. So that was one of the key tenets of the IOM report back into Error is Human. Another piece is it created patient safety organizations as an entity that could handle this protected information and analyze it and draw conclusions. So if you wanted to share data and learn from it, you had to have a safe place to do that. And finally, they asked the HHA secretary to create a network of patient safety databases so that we could aggregate across multiple organizations across the United States and glean those important lessons learned that would feed into policymaking that could improve it for all of us. So these tenets are really important and were requested or recommended by the IOM back in 1999. Fast forward over a decade from that 1999 report, and ONC asked us, speaking of what Karen said, gosh, some of the people are complaining to us that EHRs not only are not making things better, they could actually be introducing errors. So ONC asked the IOM to put together a study on, is that true? And how would we know if it's true or not? So one of the findings is, well, patient safety a decade later hasn't improved in the way that we wanted to. And furthermore, how would we make it better for HIT safety or all kinds of safety? Is we need measures to know how we're doing and whether we can do better by certain interventions. To do that, we need to aggregate data in a central repository, literally or figuratively, so that we could collect, analyze, and act on this data, learn from it, and then produce policies or technology that would improve the safety. Some of the recommendations include HHS should help us establish a mechanism so that we could report. Remember, the stimulus here was how do we understand whether HIT, EHRs are themselves creating patient safety risk? So how would we gather this information? And then importantly for this group, it recommended that Congress establish an independent federal entity for investigating, very much like NTSB, of course. So this was part of the recommendation, looking at patient safety events or risks from HIT or EHRs. So fast forward another decade, and we have the review that we just completed. And this is a peer review. And so it's not the traditional consensus study where you spend 18 months and come up with recommendations that are word. In a peer review, we're taking this congressionally mandated report that Congress asked AHRQ to produce and said, hey, ask now NAM to review that and give you feedback, just like you do peer review of a paper. And lo and behold, part of our findings or preface really is we're still at a relative standstill in patient safety progress. And we ain't going to get where we want to. The trajectory is not likely to produce the improvement we want. And what I think is really germane and really exciting about being part of your group, about participating, is the committee felt that the timing of this sort of review of what's gone on in the past decade is a good opportunity to take a step back look and say, is now a time to take another leap forward in the infrastructure needed to improve patient safety. So we had a small committee that I was privileged to chair of folks that have been in this business on different perspectives of patient safety and the evidence base. So AHRQ, as I said, that they were required by Congress to ask for this peer review. They gave us a charge of answering these 4 questions. Are there additional strategies or to reduce errors or improve patient safety that we didn't mention in our draft? Are there new evidence about effectiveness of particular strategies? What other methods can we use to improve the adoption of successful strategies, and other technical comments on the report? So I'm just going to go over some of the highlights that pertain to your activity. The first thing I wanted to do is let's put those questions in the context of what Congress wanted when they put forward the PSQIA. And that's how we interpret it. When we looked at the legislation, it's very clear what their intent was. It was to analyze things you get from national regional data so that we could learn the patterns to improve patient safety systemically. That just was very clear. Now, interestingly, the Congress asked AHRQ to produce a report 18 months after they got the NPSD up and running. I'm not sure they expected it to take 15 years in 18 months, but anyway, that's where we are. So what's new since that time of 2005? Well, one, what's new is that there's nothing new about what we've learned. We still have the same, essentially, risks, and we haven't made substantive changes to improve upon that. But something has really happened, as I alluded to earlier. We have literally in the past 10 years gone from less than 4% to over 95% of docs and hospitals now use electronic health record systems. That means we can collect data more easily. That means we can analyze aggregate data. And really important for me is you can feed back what we've learned back to the point of care so we can change all that. That's, I think, one of the most exciting pieces that may be overlooked in the analysis and aggregate data piece. So that's the reason why our committee thought this is a tipping point for us to leverage what we were enabled by the PSQIA to now act on those recommendations. So I'll go through quickly the 4 questions. Additional strategies. One of the complaints, so the majority, but that's only 59% of hospitals were, and they only focused on hospitals, we're working with PSOs, but it's not clear whether they were just consultants to them as an organization, or were PSOs using aggregate data to learn from the entire field across the country. That's not clear. So how do you get more people to participate? Because most of the people who didn't participate said, hey, I'm already doing this stuff anyway, what does it add? So like anything, it's a cost benefit, it's an ROI. How do you improve the benefit and how do you reduce the cost? So one of the increase the benefit, again, in today's world compared to 2005, we now have better methods for dealing with aggregate data so we can get additional insights that any one organization can't necessarily get. And we also can reduce the burden of having this separate process to gather all this data. Let's get data specifically out of what already exists in the EHR. And David Klassen is one of those people who championed these methods. Let's put some of them in the common formats. In other words, some kind of standardized way so we can aggregate data and analyze it across the set. And what was really confusing people is what really is and isn't protected anyway. And so I think just like HIPAA was initially a very confusing piece of legislation, this notion of what's protected is confusing, and just clarifying that would increase the value of people working with PSOs or working on this patient safety data. What new evidence have we gotten? Well, one of the important documents that we examined was OIG's report, Office of Inspector General, just in a year and a half ago, looking at PSOs and looking at what are the benefits, what's been accomplished, and what are the challenges. And a lot is the confusion I just mentioned. People don't really know, one, what's really protected, and two, what's the benefit of sharing anyway. And this is a voluntary program. So I think it's a chicken and egg. You got to show people what's the benefit in order to get them to engage. And then we raise the tide for all the boats. And we also mentioned that there are a number of other initiatives. The draft AHRQ report talked mostly of the stuff they funded, but there's lots of work going on federally and in the private sector, and we asked them to take a look at those things. Third question is, well, what are methods for encouraging adoption? Well, it's the standard sort of implementation science. And the way you get people to buy in is to show the value. And so how do we prove to the people who have to either spend money or actually do work, like the reporters, that this is going to make their lives and their patients' lives better? That's the sort of the question that hasn't been clearly answered, and the answers articulated to the people you need to convince to participate in this program. And just use standard behavioral economics. Tell them how you're protected, just like in the aviation industry, and why you reporting would get actions back that would benefit your ability to care for people. Then we had some technical comments that I won't go over, but AHRQ's been sponsoring a series called Making Healthcare Safer, which is a real big compendium of safety efforts and literature. We didn't quite know how they picked what topics, and we saw that there's some topics that are missing, like clinician burnout obviously affects patient safety. Didn't see that covered, or EHR safety. So a number of technical comments we had on the report. But I want to highlight some of the strategies we thought, if you organize it, what would enhance the value? It's the value proposition, and what would decrease the cost. On the enhanced value, we think that there's so much confusion and skeptics out there. Why should I spend this cost or this effort, that we really need to fund a demonstration project that clearly shows how can you easily transmit this data and get back information that benefits your care providers and patients at the point of care. How can you use artificial intelligence to enhance the insights we get from aggregate data? Clarify these legal protections and generate some incentives from payers, including CMS, and all the benefits of learnings from this aggregate data. On the burden side, the big news, of course, is how do we get EHRs to be able to spit out information automatically as a byproduct of care that would feed these data sets? And how can we use AI to even reduce the burden? So a lot of this data is actually in unstructured text, and AI now, natural language processing, can help us get some of that information out and codify it. It can also help us facilitate use of these common data elements. And we said, hey, why don't you update us on how you responded to the OIG report recommendations. So some parting thoughts. Basically, we've just lost 600,000 American lives to COVID. We lose hundreds of thousands every year to patient safety. We leave a lot of lives on the table. And that's our main motivation. That PSQIA was really a true enabler, because we just can't get here from there if we don't protect the data and its submission. But that this instrument that was born out of that fiscal scandal was really instrumental in causing us to computerize our industry. And it's made it possible to collect data, but just as important, as I was mentioning, it's the efferent arm of action. So it's not just another report and analysis that sits on the shelves. It can literally change care at the point of care. So we need some things to be able to stand that up. We need the demonstration projects to get us going, and the business case for sustained improvement. A lot of this, by analogy, goes to aviation. How proud we are of aviation safety just didn't get born overnight. There are very specific data and very specific policy and very specific, for this group, entities like NTSB that are part and parcel or central to that mission. So this may be a time to revive the thought behind PSQIA, and really a time for a full court press to creating a nationwide learning health system. So if you look at glasses, it's either half full or half empty, and we choose to make this look like a half full opportunity, and actually a moment in time where we can stand back and say, hey, with this new look back, with this AHRQ report or our peer review, let's get on the ball again and try to make substantive changes to increase our chance of improving patient safety. Thanks so much, Karen.